Okay, I think we can get started. Hello, everybody. Welcome to another campus lecture. Hello, Carl. Very nice that you're with us today. Carl Zimmer is probably one of the most known science journalists in the world, at least for me. I met Carl years ago, actually, here in Zurich, and then we stayed in touch and we tried to meet again at the World Congress of Science Journalism, which I think didn't work out because he finally didn't manage to come over. That was pre-COVID times. We stayed in touch. And I'm really happy that today you're here. So Carl, for those who don't know Carl yet, so he's a very popular science writer, journalist, and columnist. He writes books as well. He writes for the New York Times, for National Geographic, and many other magazines. Carl received his BA in English at Yale University and has received numerous awards. Maybe I'll mention just one, the National Academy's Communication Award, which is a quite high-level prize for science communication. So he's really one of the leaders in science communication. And he's also actually an adjunct professor at Yale, where he teaches science communication. And in that context, also he came to us, to EPFL, where we launched recently a first class on science communication. He gave a guest lecture a few weeks ago to the students, to PhD students. Thanks also for this. And today he's giving a lecture on science and policy during the pandemic. Before I give you the floor, just one remark to the attendees. So as usual, you can put your questions into the Q&A and we will ask them later to Carl, and I'm looking forward to discussion afterwards. Welcome, Carl. Thanks a lot. Looking forward.
Thank you, Mirko. It's great to be here. Thanks for having me. I'm going to talk today about the pandemic because that's been really the focus of my reporting for almost 2 years now. Many of us science writers switched over to just focusing on the pandemic when it first became such a significant problem. I think we all maybe kind of imagined that we as science writers would be kind of done with the pandemic, just in the sense of working on it from the science perspective. But I can attest that for me at least, I'm just working as hard as I was back in March 2020 when I first started working on the pandemic. And so it's but we've been into the pandemic long enough that it's not just the science that is the story, of course. It's how that science gets used to fight this virus. And I think we can start to learn some lessons, and I really do think that these are lessons that we actually need to learn, not just for the distant future, but for how we deal with the pandemic right now. So I have some slides, so I will share those for my talk. Yep, there we go. Great. Okay, so so the title of my talk is Science Policy During the Pandemic, the Good, the Bad, and the Ugly, with apologies to Clint Eastwood and Sergio Leone. So as you'll recall, in January 2020, reports started coming out of the city of Wuhan in China of a mysterious pneumonia, and we were seeing more and more cases of a disease that didn't even really have a name yet, that was being caused by a coronavirus, a new kind of coronavirus that was named SARS-CoV-2. And it became clear that we were dealing with a pandemic. So what do you do in a pandemic? Well, scientists had learned a lot about pandemics by the time that we were entering this in January 2020. And in fact, it had been about a century since modern medicine had dealt with its first big pandemic, the influenza of 1918, sometimes called Spanish flu, although it didn't come from Spain. And many lessons were learned there about how viruses spread from person to person in a pandemic. There were studies on masking that were done at the time. There were attempts at vaccination, but those were not successful. But on the other hand, a lot of our clinical trial design for vaccines was establish from those lessons. So again, so scientists and doctors had been studying pandemics caused by viruses for a century when SARS-CoV-2 started. And with coronaviruses in particular, it's been about 50 years since June Almeida and her colleagues first recognized that there was a group of viruses called coronaviruses. And this picture here, you can kind of see the fuzzy outlines of these spike proteins, which gave their name, coronavirus, referring to the corona, the streams of hot gas that you can see coming out of the sun during an eclipse. So at the time, coronaviruses were known to infect animals and some infected humans, although as far as I know, could tell, they really only caused mild cold. So people didn't pay a lot of attention, admittedly, to coronaviruses. There was a small group of coronavirologists who just plugged away at these. But you know, it was 18 years ago that actually a coronavirus really showed us just how much potential it had for harm. This was what's called SARS-CoV, which is a coronavirus that causes the disease SARS. So first cases emerged in 2002, and then again in 2003. There were over 8,000 cases worldwide, over 700 deaths, and that taught us again a whole lot about how to be ready for a pandemic like this, a pandemic caused by a coronavirus. There were studies done on how the virus is spread. There were vaccine trials that were started up, drugs that were begun to be tested for it. Also, the sort of evolutionary roots of pandemics really came to light in a big way, thanks to the research on SARS. So here, what was basically figured out was that there were viruses in bats, and that these coronaviruses spilled over into humans, in particular Chinese horseshoe bats, appear to be the origin of SARS. Now, we were lucky that SARS turned out to be pretty limited, shall we say. If you got SARS, you were in a very serious risk of dying, but relatively few people died because quarantines and isolation were able to sort of break the transmission of this virus. Now, as if that wasn't enough preparation, we had another coronavirus that emerged. This was in 2015, and this was not in China, but in the Middle East. Middle East respiratory virus, Middle Eastern respiratory syndrome coronavirus, or MERS-CoV. And here, the importance of an intermediate host also became clear, in the sense that this virus also started in bats, most likely, but then it adapted to camels, and then people in contact with camels kept picking it up, and then eventually it started to move from person to person. Now, again, we were lucky that this was a pandemic that wasn't a pandemic, I should say, but it was a it was a virus that has never been able to move very easily from person to person. We'd be in big trouble if that was the case, because it has an even higher fatality risk than SARS. If you do get a MERS infection, you're in big trouble. But again, through control, especially in hospitals, hardly anybody gets MERS anymore. So, in addition to this sort of history of knowledge about pandemics and about coronaviruses, scientists by 2020 had a lot of tools that their predecessors didn't have. So like gene sequencing, for example. researchers could take a swab from someone like was happening here, and if they had the coronavirus, they could actually sequence the genetic material. And this happened very quickly. In January, scientists, after the SARS-CoV-2 had been isolated, they sequenced the whole genome, and there was some, back and forth about whether this could be shared. There's some reporting coming out that has come out about how the Chinese government appears to have gotten in the way of that. But basically, January 20th, this is a website called Virological. A researcher named Edward Holmes just said, "Here you go, world. Here's the genome," and so that in itself was remarkable. But what was even more remarkable is that scientists could immediately take that code, that sequence, and start to do all sorts of things. They could, for example, start making vaccines and testing them. They could recognize genes for particular proteins and produce those proteins in isolation, and then crystallize them and figure out their structure. So that very quickly, we started to get a really remarkable view of this coronavirus, and to understand the differences between this coronavirus structurally and other coronaviruses. For example, scientists very quickly were able to work out a lot of the intimate details about how the virus gets into our cells. These proteins that stick off of the surface of the virus, spike proteins, they latch onto a receptor on some of our cells, including in our airway. This receptor is called ACE2, and that's like putting a key in a lock that allows the virus to pull itself towards the cell, to fuse with the cell, and then insert its genes into its host, and then new viruses come out. Now, for all that, unfortunately, the pandemic has been a global catastrophe, and this is a graph showing the cumulative number of confirmed COVID-19 deaths, which is over 5 million now, but that's just confirmed deaths. Scientists suspect, looking at the overall death rates in a number of countries, that the true death toll might be double or triple this figure. And you can see that there really hasn't been much of a slowdown. If you look at the slope here of this line, I mean, people just keep on dying. We're not flattening out, it seems like. So how high are we going to go? You have to ask. And if you look particularly at cases, because only perhaps 1 in several hundred people who get COVID is going to actually die. A much larger fraction will suffer serious symptoms, might have long-term symptoms. But in any case, if you look at the cases that have been confirmed, you see that we have sort of had this rise that eventually turned into a spike, and then with a falls, and then it spikes again, falls, spikes again, and now we're in another spike. And this is even before Omicron, which I'll get back to. But this is not the picture of a pandemic that is under control. It just isn't. So, so why is this? I mean, what happened to that century of science, to all of the new developments in science that were thrown at this virus from the start? Like, why are we still in this problem? There are a lot of reasons for that, and some of them have to do with things that happened before this pandemic. So, for example, we did not learn collectively. We did not learn the lessons that we should have already. So we knew that that wildlife is a very good source for coronaviruses and other emerging viruses. And yet, in China, which is a place where some of these viruses have gotten their start, it has not been very impressive how they have controlled their wildlife trade. There's been a lot of illegal wildlife trade going on since SARS. And, scientists have repeatedly said, like, this has to stop. We are, this wildlife is picking up viruses, often from bats, and then they are in close quarters with people. And this is a great way for viruses to hop over the species barrier. And it does, there's a lot of controversy about, where SARS-CoV-2 came from, but certainly in my reporting, it seems pretty clear that it started in a wildlife market, and that we basically saw a replay of SARS, and that is quite tragic because with more follow through on what we knew from science, perhaps this wouldn't have happened. There were a lot in China. There was a lot of secrecy about the initial cases. There was a lot of reluctance for local government officials to make a big deal out of an exploding pneumonia situation, and so in China, things really got out of control quite fast. And so these early warning systems that might have worked didn't. Testing was really important to control the spread of the disease as it spread across China and into other countries. Unfortunately, some countries did quite well with testing, created them very quickly and started using them very aggressively. In some countries, like the United States, that was far from the case. So in the United States in particular, we government scientists didn't want to just use a test from endorsed by the World Health Organization. We wanted our own. And that test was flawed, and it took a very long time for that to become clear. So basically, essentially, the virus was spreading unchecked and unmonitored for a month or more. And when you're dealing with something that can grow exponentially, that kind of lost early time can lead to spectacular damage. So just from that testing problem, thousands, tens of thousands, maybe more of people died unnecessarily. Now, another reason that there have been a lot of lives lost and a large number of cases of COVID is not so much that what scientists were telling people was not followed through with policy. It's actually that the scientists themselves really didn't have great answers. And one of the big problems had to do with how the virus gets from person to person. So a lot of scientists argued that we should treat SARS-CoV-2 a lot like influenza. And it was believed, with influenza that it's carried by big droplets, that someone sneezes on you, you could pick it up. If they cough onto a surface and you touch it and you touch your mouth, you could get sick and so on. So that was sort of the paradigm. And so, there wasn't really seen much need for masks outside of hospital settings. But there were, there was actually a long running debate about the nature of airborne respiratory diseases. And a lot of scientists have been saying we need to pay attention to the much smaller drops of water, the aerosols, because the virus, they argued, could be carried along by aerosols, and those aerosols can float. So, you could be in a room where the aerosols are just floating around and you breathe them in unless you have a mask. So this was actually an ongoing scientific debate, which was not resolved when the pandemic began, and then it just got more intense. The fact is that here's a three-dimensional visualization of an aerosol. These are lots of different molecules from your lungs that are inside of it, and there's the virus. And then the fact is that, yes, indeed, SARS-CoV-2 can be carried by these aerosols. Epidemiological studies eventually made that clear, that there were people who were, at some distance in a unventilated indoor space who were getting sick because these things were just floating around. Again, unfortunately, the nature of science sometimes doesn't lend itself to making big advances in the middle of a crisis, and that's really unfortunate. I mean, the fact is that for many scientists, the gold standard of evidence is a randomized controlled trial, and there really weren't particularly good randomized controlled trials of wearing masks before the pandemic. There was a very small one in Denmark that seemed to suggest that masks didn't work, but people pointed out that it was so small and the way it was designed, it really wasn't, it really would only show a result if there was some gigantic benefit of masks or not. And so it wasn't actually until last month that a randomized controlled trial that was big enough and well-designed enough to really address this issue finally delivered its results. And yes, indeed, masks do help. We're talking perhaps cutting 10 to 20% transmission, which, is not everything, but it's a big deal. And combined with other efforts can actually reduce transmission a lot and reduce the number of people who die. But almost 2 years into the pandemic was finally when the scientific community was able to deliver those results, and millions of people were dying in the meantime. So I mentioned vaccines before, and this is just over a year ago. I was a co-author on our article on the first evidence from a randomized controlled trial that any vaccine could be effective against a coronavirus, for SARS-CoV-2 in particular. So, this was not only a welcome news, but this was historic news because, in fact, vaccines traditionally take a decade or more to be developed and reach the clinic. So here you have under a year, you have a vaccine for an entirely new virus that is being designed, and the first ones, such as Pfizer and Moderna, they were using messenger RNA, which was an entirely new platform for a vaccine, entirely new in the sense of it had not been approved before for humans, and so it was a big question of well, how's it going to work? And it works quite well, as these trials show. This didn't happen on its own. There are reasons why vaccine trials took so long before, and there are reasons why this one was so fast. And a lot of that has to do with how regulators decide what is actually necessary to determine if a vaccine is safe. What are the sort of the stages? And a lot of it involved government support, because a big reason for the speed of these trials was that you have several stages of vaccine development. So you have the preclinical stage where scientists are making the vaccine, they're testing it in cells, then in animals, and then you have the clinical stage where you're testing it on people, and now you have those 3 phases of clinical trials. Now, at each step of the way, an academic group or a company might stop, take a look at the results, and if the results are good, they would then start to take the steps to prepare for the next step. Now, that might mean, for example, looking at tests on, say, mice or monkeys and seeing if those are good, and only then saying like, okay, let's do all the work of setting up a clinical trial with thousands of people. Let's start making the vaccines in enough quantity to run these bigger trials. And but with the right kind of support, these vaccine makers were able to say like, okay, while we are working on the research in this stage, we will actually be preparing for the next stage. That's a risk, because what happens if this stage fails? There have been plenty of vaccines that have failed. And so, all that work that you're putting in for the next stage would be for waste. So things like advanced purchase orders and other kinds of support, grants, and so on helped to accelerate this process. So, unfortunately, we're a year into the pandemic before vaccines started being distributed. Now, for people who got them, they did provide really good protection, especially against severe disease, which is what matters most. And there are a variety of them that have been authorized. So Comirnaty's from Pfizer, Moderna from that company, AstraZeneca has one. Then you have Johnson & Johnson to the right, different platforms, but all effective to varying degrees. Unfortunately, the world is not as highly vaccinated as we had hoped, or as it needs to be. And as you can see here, a big part of that problem is that we are living in 2 worlds, essentially. We're living in a highly vaccinated world of high income or middle income countries, and then another world with a substantial fraction of humanity in low or lower middle income countries. And you can see that the coverage of vaccination is wildly different. Again, that's not a matter of science, that's policy. That's government saying like, okay, governments that could afford it said like, okay, we're going to buy a lot of vaccines in advance, and we're going to lock up the supply. And then these companies have not really had much incentive or interest to really to overcome that and to get these vaccines to these low-income countries. There are international efforts. There's one called COVAX to try to get more vaccine equity, but as you can see, they're really not very successful so far. Now, along with vaccines, there are, along with prevention, like masks and testing, and along with vaccines, there are treatments for people who get sick. It's very much the case that, like, to know whether something is going to work against COVID-19, you really have to do the work. You have to do a randomized clinical trial, and it has to be big. And in the cases where people have done that work, we've actually gotten, some important results fairly early in the pandemic. So this is from a British trial network called Recovery. They just decided to take a lot of existing drugs where they thought, well, there might be a possibility that it helps, and to say, well, let's put them into trials. Let's give them, let's randomize big groups of sick people half of them will get this drug and half of them will get a placebo. And let's really see if there's any really clear result. So, aspirin, for example, that was one of the ones. Many others that are less familiar, but in any case, most of them turned out in the recovery trial not to have any effect. But there were some that did, and maybe the most important one was a steroid, something to calm down the immune system, called dexamethasone. This is a cheap drug that's widely used, and if people are having problems with their sort of runaway inflammation, and when they're in the hospital, dexamethasone is really effective. It reduces deaths by up to 1/3 in hospitalized patients. And as you can see, this was something that was became clear in June 2020. So just a few months into the pandemic, having this trial system set up and being supported delivered a finding that probably has saved millions of people by now. This is an incredibly important finding. Now, unfortunately, in the United States, we have some trials that kind of work like recovery, but we've also had many more other trials that have not worked like that. There haven't even really been trials. They have been just sort of mad rushes for different kinds of treatment. So convalescent plasma, which comes from the blood of people who've recovered from infection, at first that seemed like that might be a really good sort of stopgap way to save lives. And so you had thousands and thousands of people like this soldier who had recovered from COVID-19 volunteering and giving their blood, and from their blood, the plasma was being extracted, and then that was being given to people. Now, there were scientists who were trying to study convalescent plasma and see if it worked. But really, as this is an article that came out in this April, what happened was that the U.S. government rapidly authorized using convalescent plasma for COVID-19 based on relatively little evidence. And a lot of scientists at the time were saying, like, you don't have the evidence to do this. So these trials were still going on, these large trials, but meanwhile, tens of thousands, hundreds of thousands of people were getting convalescent plasma to treat them. And nobody was really studying those people in a rigorous randomized way. So we weren't learning anything from what they were going through. If they got better, did that mean that the plasma did it? Or were they going to just get better anyway? By this spring, the evidence was finally becoming clear that convalescent plasma wasn't really showing clear signs of working, especially when it was being given to people who are already hospitalized. By then, it was just far too late for antibodies from people who recovered to do any good. And the WHO has and the National Institutes of Health have sort of their attitude now is that convalescent plasma shouldn't be used. Only if there are randomized clinical trials to look for any benefit in some particular circumstances, that's fine, but it's not a panacea. It's not going to help. And it took us a long time to find that out. And we could have had that answer pretty much as soon as we had the answers about dexamethasone. But we in the United States, we did not have a policy that clearly, strongly supported doing the hard work and waiting for those results rather than rushing for something and saying that we can't wait. That was a mistake. Just recently, my colleague Rebecca Robbins and I, we've been covering the emergence of treatments and that are really promising. These are antiviral pills, but you know these took a long time to really get supported, and you know, we're really 2 years into the pandemic, and only now are these drugs starting to emerge. There will probably be even better ones than this molnupiravir. Molnupiravir reduces the hospitalization death by maybe 30%. There may be pills that are much more effective, maybe taken in combination. But again, that research is going to take time, and it's also going to need sustained support. You know, researchers can't, you know, sort of dive in, do a little bit of research, and then walk away. It takes a long time to make these drugs, and then it takes a long time to test them. It's harder actually to speed up the process for these drugs than it is for vaccines, ironically enough. We're in a better place with testing now. So instead of those terrible tests that didn't work at all, we're starting to have more and more tests that are available at home. And you know, so those could potentially stop transmission. You know, so if people test positive, they quarantine, and they don't get other people sick. It's simple stuff, but you know, it's challenging. The virus makes it challenging because you can be infected and spreading the virus without even feeling symptoms, so you may not realize that you're sick. But also, certainly, supply makes a big deal. So in some countries, you can get tests for free. In some countries, you can get them for very little money. At least up until now in the United States, you know, if I wanted to go buy this BNext Now test, for example, I have some of them in my bathroom. It comes out to about $12 a test. That's pretty expensive. If you expect people to be regularly testing themselves, you know, perhaps every week or several times a week, that's just not going to work on a large scale. That doesn't make sense on a public health level. So, so the Biden administration is finally coming around to trying to make these more accessible, but we'll see how much they're put into use. So just to wrap up, and then I'm happy to talk with Mirko and you know, respond to particular questions you may have. You know, no talk about the pandemic in December 2021 would be complete without talking about Omicron. I and my colleagues at the New York Times were writing about Omicron, so just to remind you, this is we've had these new variants that have arisen from time to time. You may remember Alpha, you may remember Delta, because Delta is actually the dominant variant in Europe, in the United States, and most other countries. That sort of came to dominance this summer because it had a number of mutations that allowed it to spread more successfully than earlier variants. And then just last month, researchers in Botswana and South Africa noticed something a little odd about some of the samples from patients. So they took a closer look and, you know, looked at the mutations in these viruses and found that they were looking at a new variant, which is now called Omicron. South Africa Southern Africa immediately got blamed for Omicron, even though it's not actually clear where it started. And so travel was banned from those countries. Of course, it turned out that all the countries that were banning travel from Southern Africa also had Omicron. So it's here in the United States, it's across Europe, it's basically everywhere. So scientists are trying to understand what these mutations in Omicron mean. This is a one representation of that spike protein I was showing you. Wuhan refers to the original strain, and then there's Delta and Omicron. And these different dots show different parts of the protein that are being altered in different ways. And so you can see that there are a lot more mutations that are altering the protein of Omicron than Delta. As far as we can tell, and I'm literally just talking to you after having spent the morning watching the latest data from the World Health Organization in a presentation, it looks as if Omicron may have the ability to spread quickly. It's not clear if it spreads more quickly than Delta under all the things being equal. But it also seems to have the ability to evade the immune system. In other words, if you got infected with Delta, you'd produce a bunch of antibodies to Delta, and those would last you a long time for a number of months. So you would be very unlikely to get reinfected. Omicron shows up, and it seemed the antibodies that might stick to the Delta spike, a lot of them can't stick to the Omicron spike. So that in South Africa, there's an explosion of cases where what seems to be happening is that Omicron is evading defenses that people got from being sick before. So there's a growing number of people who are getting reinfected thanks to Omicron. It's really hard right now to say what exactly that means for the rest of the world. What does that mean for people who are vaccinated? There's questions about, well, how severe is disease caused by Omicron? We're literally waiting day by day for the answers for that. So we're in a very new very uncertain time. Ironically, that's kind of how things were when we started in March 2020. Where we didn't know a lot. Or I should say January 2020, we didn't know a lot, but there were reasons to be concerned and to get the science done quickly and to listen to what the scientists were saying. Scientists are not just waiting for Omicron to spread to kind of understand its epidemiology. They're also doing experiments in labs, and they're doing research like this is basically trying to reconstruct its evolution to try to figure out, well, where did Omicron come from? It's a SARS-CoV-2, so it descends from the original SARS-CoV-2, but it may have, some people have suggested that it may have infected someone with a weak immune system, like HIV, and so that they might produce antibodies to COVID-19, but they're pretty weak. And so that gave the virus the opportunity to replicate and mutate and evolve and adapt, and then gain a whole bunch of new mutations. And then it came out of that person and has been spreading, particularly in South Africa at high rates. So, so right now, a lot of what we need to do to deal with Omicron is kind of what we needed to do from the start. As I said, to mobilize science, to support that science in a sustained way, to not punish people like South Africa for actually doing the science and being transparent about it, to recognize that it's a global problem, and so nations sort of being very selfish is not a smart long-term solution. Mike Ryan, who is at the World Health Organization, has said something that has been quoted a lot. It says, "Be fast, have no regrets." In other words, fast responses, even if they're not perfect, can be incredibly important because they allow you to cut off a fire before it's basically out of control. But the one thing I will point out is that that date on that quote. This is a tweet from Sky News quoting him. You see, that's March 13th, 2020. So he was talking about the start of the pandemic and telling people we need to act fast. People did not act fast, and we paid a price. But that advice still works. So thank you so much for your attention. Yeah, happy to take questions or address things that I didn't talk about in particular there.
Excellent. Thanks a lot, dear Carl. So I see there are already questions coming in. Maybe I'll start with one. So how do you see this big opening? I say it's this divide between, on one hand, facts, science, the other hand, of course, fake news. I think last time you mentioned, or maybe I missed a beat today, also a tweet that has been picked up by President Trump of yours. But it goes much more than between facts and fake news, right? It's also, in Europe, it's becoming a polarization between, that's the word actually I was looking for, polarization between kind of technocracy and democracy even, right? And so we vote on things that are often on a scientific ground, not always the purest. So how do you deal with that weight as a science journalist to really defend the truth in some sense?
Well, I think that one of the things that journalists need to do, I mean, there are a lot of things that it's important for journalists to do in a crisis like this, but one of them is to write about science reflecting how science actually works. So how do we know what we know, and how do we find that out? And so when the advice became, we really need to be wearing masks and need to be wearing them on a large scale, there was this, you could see a reaction among some people of like, well, you didn't say we needed masks before, and now you're saying that we do, so why should we believe you on anything? And there certainly are scientists who were arguing from the start that we needed to have masks, and I'm sure they feel that that should have been a decision made faster. But nevertheless, the fact is that science is not a sort of it's not like there's some sort of that scientists have this sort of truth given to them from on high, and that's written in stone tablets, and they just pull away the curtain, and there it is. Science is a process, and a small study may provide some promising hints, but then a larger study, a more rigorous study, may actually go against that, and that's okay. That happens all the time with science. So I think that a lot of people are not, may not have really paid much attention to science until now, and all of a sudden, they're coming to it with a lot of expectations. And so I think that science writers have to remember that, keep that in mind, and just so that when they're writing about these things, that people can understand it, can see how to weigh the evidence, and not be misled by false claims. There are a lot of people who make claims about vaccines or about different treatments. They sound sciencey, but if you just look a little more closely, you realize that it doesn't hold up at all. So the hope is that people who make the effort to read the science journalism will start to learn to recognize the difference.
Thanks. Maybe a follow-up question, then I'll take some of the chat. So there's been recently some articles, I think, in the American press, also arguing that science journalists and science communicators should maybe move away from a model where we take a paper and translate it for the larger public, but really go one level higher, try to integrate many papers and also discuss with psychologists, politicians. So maybe exactly to show a bit science as a process. What do you think of this approach? Is science communication maybe a bit old in a way we're doing it? One paper, one news?
Well, I mean, I'm all for, you know, the new and innovative ways of writing about science, you know, and certainly, you know, there's a place for, you know, really, you know, detailed accounting of particular research. You know, there has to be reporting on politics, on policy, on how people are sort of reacting to science. Like, it's all part of the same effort. But, you know, I would say that it is, you know, there's so much news now. Like, you know, when we're done talking, I imagine I'm going to check my email. My editor will probably have like a couple things that I need to write about this afternoon. Like, it's coming so fast, and you know, we just have, you know, we are trying to keep up with it, and you know, it can be challenging to find the time to do that more kind of that richer, bigger, multi-dimensional approach to science, when there's just like a long line of breaking stories like today that have to get written about. So the reality of the situation sometimes can create real challenges for trying to go in these directions.
Thank you. So I'll take a question from Pasquale Di Cesare. So he says, you did not talk much about how epidemiologically different geographies and countries performed so far. Can you comment a bit more on the lessons learned from different areas and geographies?
Yeah, great. That's a great point. Well, you know, you can, if you line up different countries, you know, there's a website, Our World in Data, which has got great tools for this, you know, where you can just, you know, say like, I want to look at, you know, daily confirmed cases, and I'm going to like add, you know, a really interesting comparison would be, you know, say United States and South Korea. So if you check that out, I like that one in particular because the United States and South Korea have recorded their first cases of COVID-19 on the very same day. And then if you follow like where things went from there, in the United States, we basically, you know, we weren't testing. You know, President Trump wanted people to just go about their business and everything was going to be fine, and we didn't really need to do anything. And that sort of continued to be true like into February and into March, and then suddenly in March we had this explosion of cases, and in South Korea there wasn't an explosion like that. And the reason there is that they, probably having had that experience with MERS and with SARS, they took coronaviruses seriously. And so they were supplying masks, they had production set up for masks, they had tests immediately and put them into widespread use. They were protecting their healthcare workers. They were doing really aggressive contact tracing with a really robust public health system. They did all these things. And so really for the first, you know, year and a half of the pandemic, it's just a really stunning contrast. You know, the United States has, and lots of Europe to some extent, have been kind of a bloodbath, whereas like South Korea was just like very, very modest cases. And whenever outbreaks were found, they were reined in. Unfortunately, you know, in the past few months, they have started to have increasing cases. Still nothing on the level of the United States, but you can see that they're going through some spikes, and part of that is that the Delta variant arose, and that Delta variant turned out to be so good at spreading that even what South Korea was doing, that was keeping earlier variants in check, wasn't enough, and so Delta was getting out, spreading, and ironically, I think that the countries like South Korea or Australia, who are doing a really good job at keeping cases down, they seem to have had a little bit less urgency in terms of vaccines, in terms of preparing to roll out vaccines, to secure doses and so on. So their vaccinations were kind of slow at first, and that became a problem because they didn't have as much protection from vaccination, and that contributed to the problem. So I don't think any country really has gotten away with perfect. Well, I guess maybe New Zealand, I don't know, or Taiwan. They've been doing remarkably well, but for the most part, as these variants get more transmissible, it just gets harder and harder to really keep it in check, unfortunately.
Thanks. Maybe to speak of another area, there's a question around China, Russia, and what's your opinion on the approval of the vaccines coming from China and Russia? You think there's a Western lobby slowing this process down? And what is the role of the media as well? Do the sources are really anonymous, scientific, or was it Reuters?
Right. So, so there's like two levels of authorization. So, Sputnik, was or Sinopharm and Sinovac in China, like the first stage is getting authorized by the nation where a vaccine is developed. Then the World Health Organization can consider it for their sort of set of vaccines that are kind of approved across the board. I mean, I think that there's been a lot of there's been a lot of sort of questionable process with the vaccines in Russia and China, simply in terms of knowing about what's going on. How well do these things work? So Russia, for example, was extolling Sputnik. I'm just trying to basically in like late 2020, they were already saying that it worked before they had any phase 3 trial data to share. In fact, and in China, they just started vaccinating people with Sinopharm and Sinovac, I think even before the phase 3 trial had started. And so it's just been, so it just becomes very difficult to figure out like what's going on with these things. Another issue is manufacturing. There's been a lot of reporting that there's trouble in Russia with Russia's manufacturing of Sputnik. A lot of questions being raised. So I don't know when Sputnik will get authorized by WHO. Sinopharm and Sinovac, the big issue there is, I mean, these are going widespread use, but they are a particular kind of vaccine, an inactivated virus, which doesn't seem to be a really great choice for COVID. Their effectiveness never gets to be very high, and it seems to wane pretty severely. And so people are getting boosters. In a lot of countries, they're just switching over to an mRNA vaccine for a booster. So yeah, there's a European inactivated virus vaccine called Valneva, which in a recent study did not compare very well as a booster to other vaccines. So so that's another issue. It's like what kind of vaccine are you making?
Thank you. Maybe moving a bit into the future and watching towards the future. So how do you think that early attitude of different countries will impact the pandemic on the long run? Do you think that countries that had a zero COVID strategy will eventually also face high rates of infections? How do you see the evolution of different countries?
Yeah, well, that's an interesting question. It was certainly, well, I mean, like a country like South Africa, for example, has had really high infection rates. In some cities, it's like as many as 80% of people in these surveys seem to have antibodies from COVID-19. Whereas like in Australia or New Zealand, virtually nobody has. And that's good for those countries that had that kind of zero COVID policy, in the sense of like, lives lost. Like they saved a lot of lives, but the only immunity people are going to have going forward is from vaccination. So I think that, if you go for zero COVID, which has a lot going for it, you have to deal with like the huge sacrifices that people are making in their lives, emotional, financial, and so on. That's a big deal. But also another big deal is that like you have an immunologically, naive population. And so if Omicron shows up and is incredibly transmissible and people have no immunity at all, like that can be very problematic. So I think that I suppose in a perfect world you would have really aggressive testing, contact tracing, keeping cases down as far as possible, and getting vaccines designed and trialed and distributed as fast as possible, because you have this. You don't have any immunity from infections.
Thank you. And also regarding the future, how do you see the endemicity in 2022? Question is, do you think that it could become endemic already in 22? And if so, in which areas? Those with high or low vaccination rates? What's your take on that one?
Oh, that's a great question.
Predicting the future.
Right, but imagine we were talking about this question last month, where the Omicron didn't exist. I mean, like we would make a whole bunch of claims based on Delta, and that would be it. Omicron, it's possible that Omicron is something that really only like takes off in South Africa, because of their particular experience with the pandemic. That's possible. It may be very different. I mean, we're going to find out. I mean, this experiment is happening right now. Omicron, I live in the state of Connecticut in the United States. It's here in Connecticut. I don't know, have they found it in Switzerland yet? I mean, it's in France and Italy. I mean, it's got to be in Switzerland too. So we're all going to run this experiment. We'll see what happens. But, in terms of like endemicity, it's this idea of a virus that's just circulating around and we're never going to be getting rid of it. Like, it's hard to see. I can't. It's just this virus. I can't see how we eliminate it, especially because it is able to spread from people who don't even know that they're sick, or very mild symptoms, and to potentially infect a lot of people in the kind of situations that we are frequently in when our lives are normal, at schools, at restaurants and churches, and in indoor spaces. So that's one of the things that makes vaccination even more important.
Yeah, thanks a lot. So maybe a bit less predictive questions. We go a bit back to our métier, science communication, journalism. So you developed, for example, I remember that quite early on with New York Times, the COVID tracker, right, where you could see the different vaccines being in the different pipelines, or a fantastic article about the different genes in the genome, or the Neanderthal genes. That's the things I always like and follow you on Twitter. And how do you deal with the fact, actually, somebody's asking that these news actually stay in the English-speaking area, right? I follow them on Twitter, I see them in English, but they never reach the Swiss press because we speak different languages.
Well, you know, if there's you know, if there's I don't know, I'm not on the business side of the New York Times. I mean, it would be great for us to have a Swiss edition. I don't know what that would take. I mean, certainly like we have, you know, made efforts to translate some of our COVID material into other languages, especially Spanish, because you know, Spanish speakers in the United States, but also the Spanish speaking world more broadly. So yeah, I mean, it's a challenge. I mean, you know, certainly science writing is a challenge, sort of broadly speaking, because you know, you know, if you're there are a lot of newspapers are struggling, and so they may not have like the resources to support people who are just writing all the time about COVID. You mentioned the vaccine tracker, and so there, like, we've created a resource where we're following. I guess we're over 100 vaccines in clinical trials, and just keeping those up to date so that people have a resource to go to. And that takes efforts of a number of people. So yeah, so, you know, a small newspaper can't do that. So I wish I had a great answer for that. I mean, it is a serious problem,
No,
but
course,
like, I think it's a subset of the problem of like, oh my God, what's going on with journalism? How do we fix it? And
of course.
I don't have a great answer for that.
No worries. I wouldn't call the New York Times a small newspaper, I guess, compared to our little.
Oh no, I agree.
Okay.
No, we're right, but that's my point. That's my point is that you know, journalism cannot rely on a few large successful newspapers. It's just, that won't work.
Yeah, absolutely.
Switzerland needs Swiss newspapers to address what matters to the Swiss, and that's true within countries as well. So in the United States, you know, we're losing a lot of newspapers that serve our, you know, our smaller cities, you know, Baltimore or Denver, so there's a lot that's lost there, specifically having to do with medicine and science.
Thanks a lot. I see there are no further questions, so maybe I come back a bit to the initial questions I had. So we talked a bit about, you know, the science as a process and the role of science writing to show this process. But at the same time, I'm still seeing a bit of a tension growing. We have, you know, I mean, there is a limit, right? There is something that is the best knowledge of the moment, right? And if that knowledge can be overthrown by a democratic vote, that can lead to an issue, right? So we had votes in the past in Switzerland where a majority decides on something that is not necessarily scientific, for example, homeopathy. And, you know, so again, I'm making it up as we speak, but if people should express themselves, if the world was flat or round, and if they would vote for flat, would that still be part of the scientific process, you know? And you see what I mean? So I think the role has become more difficult actually for science writing in this polarized time. And so again, my question, what stance shall we take, you know? So one is definitely showing the process itself, but there seems more to it, right? Science seems to touch policy more than ever, which is the title of your talk. Huh?
Yeah. Well, I mean, I think that, you know, science touches so many parts of our lives that, you know, we would do well to understand it better. But we can all, you know, work to improve our understanding, even if we have an expertise in some particular area. But yeah, I mean, you know, I think for science journalism, there is a balance there to say to reflect how science works. On the one hand, to show that, you know, science is a process in which scientists are testing ideas, debating each other, and that there's a lot that they might still not yet know. However, that doesn't mean that scientists know nothing, and that doesn't mean that all ideas that anybody might come up with have equal value. Coronaviruses exist. Coronaviruses are real. They just are. Coronaviruses have spike proteins. Like these are now, what does a particular mutation to a spike protein in a coronavirus mean for our health? Like, well, scientists may not know. So with Omicron, like scientists there's a lot they just do not know about yet. But they're seeking to build knowledge on a large foundation of knowledge. It's great that people are getting more engaged in the scientific discussions and processes and so on. But when people start talking about doing their own research, I get nervous, because that usually doesn't mean reading scientific reviews. It usually means reading a post on Facebook about how a vaccine will make you spoons stick to your head or something like that. So it's a challenge.
Thanks a lot. Okay, I would like to thank you in the name of everybody. I think we have been, it was very enlightening. We had like 70 minutes or more, a bit more together. Thanks again for having been with us the second time this year at EPFL. And I hope we'll stay in contact. I'll definitely continue to follow your writings and your tweets. And thanks for all that you do. And see you.
Thank you so much for having me. It's a real pleasure. I'm sorry we can't do this in person, but hopefully with vaccines and immunity, that will eventually become possible.
It would be lovely. We'll meet at some point again. Thanks so much, and have a great morning over there. I guess we start to go into the evening here. Bye bye, and bye everybody. Thanks, Carl.
Take care.